Good evening to you all. Welcome to the July chapter of the Therapeutic Forum of Sri Lanka College of Internal Medicine. This forum is established to enhance the knowledge and practices among the practicing physicians in this country. And in each chapter, we invite a different subspecialty to upgrade our knowledge and practices. Today we have Dr. Nalaka Herath, consultant nephrologist from North Colombo Teaching Hospital. Without further ado, let me invite Dr. Krishanta Jayasekara, President, Sri Lanka College of Internal Medicine, to address the gathering. Over to you, sir.
Thank you very much, Ranga. I think, as you very correctly said, this is the 6th episode of Therapeutic Forum for year 2025 of Sri Lanka College of Internal Medicine. This forum was initiated, as Ranga very correctly said, to share the expertise and experience of our peers. Because on managing patients with complex diseases or multi-system diseases, renal failure is maybe AKI may be only one part of a systemic illness, but we do manage this patient in collaboration with other peers in the field. So I think it's a high time for us to, this is a very highly timely topic where we will be listening to Dr. Nalaka Herath, specialist nephrologist from Colombo North Teaching Hospital. He will be sharing us on evolving landscape in renal replacement therapy. Without further ado, may I invite Ranga to invite Dr. Nalaka Herath and proceed with the webinar. Over to you, Ranga.
Thank you, sir. Dr. Nalaka Herath, MBBS, MD, MRCP UK, MRCP Renal, FCCP, consultant nephrologist, Teaching Hospital, North Colombo. He is board certified as a specialist in nephrology since 2013 and a fellow of Ceylon College of Physicians from 2021. Specialty certificate in nephrology in 2013 and Renal Association of UK, MRCP UK and MRCPE in 2012. And he obtained MD from University of Colombo 2009 and MBBS from University of Pennsylvania in 2003. He has President's Awards for Scientific Publication in 2012, as well as prize for the best paper in nephrology in Sri Lanka in 2010. And he has under publications, he has one book and one chapter of a book of 15 articles in peer-reviewed journals. He has played an advisory role in National Medicine Regulatory Authority, as well as Medical Supplies Division for Ministry of Health. He has been the president of Kurunagala Medical Association since 2021 and President Colombo North Clinical Society 2018, 19 and 20 and member of Nephrology Board 2018, 19 and 21 and postgraduate coordinator of World Medical Association from 2016 and 2017, council member of Sri Lanka Society of Nephrology since 2014, chairperson of Renal Regulatory Subcommittee, Registry Subcommittee 2021 and 22, and Joint Secretary of Sri Lanka College of Nephrology 2019 and 2020. Without further ado, let me invite Dr. Nalaka Herath to proceed with the lecture. In the meantime, we will be sharing the link and the QR code at the end of the lecture for the CPD certificate. And you can scan the QR code and enter your details, and you will be receive the certificate within 2 weeks. Over to you, Dr. Nalaka Herath.
Thank you, Ranga, for your kind words of introduction, and Krishanta, my friend. So let me share the screen. Ranga, have I shared a screen?
Yes, we can
Yeah.
see. Yeah.
Okay, I can select the laser pointer. Right. Okay. Good evening. Thank you for inviting me to give this talk. So I will try to brief as much as I can, and then I will give more time for you to engage with some questions. So the topic given to me was from indications to innovations, the evolving landscape of kidney replacement therapy. So first of all, so these are the objectives I'm going to cover this time. So first of all, epidemiology of end-stage kidney disease. The second, modes of kidney replacement therapy. Then advantages and disadvantages of each mode. Uh, challenges to kidney replacement therapy in poor resource setting. The management of complex case of leptospirosis and CKD-associated complications. So let's understand the epidemiology of end-stage kidney disease. So as you know, chronic kidney disease is growing global concern. A systemic analysis from Global Burden of Disease study reported 700 million cases of CKD with global prevalence of 9.1%. In 2019, approximately 1.4 million CKD-related deaths. This represents a 20% increase since 2010. CKD is one of the most rapidly rising cause of death globally. Though it is a global issue, CKD disproportionately affects the individuals in developing countries like us. A study in 2015 estimated that 390 million people in low and middle income countries compared to 110 million in high income countries. See the discrepancy. In Sri Lanka, with rise of diabetes mellitus, faces an increased burden of CKD in coming decades. Now we have 5% of diabetes burden in 2000, and now it is rising up to 24%. So it's a rapid rise of diabetic population. So, and similarly, we have only 22 nephrology units and approximately 40 nephrologists, equating roughly 1 million per 550,000 people. So we are well behind the standard numbers. The financial burden of managing advanced CKD is immense and largely unaffordable. Due to this constraint, providing optimal kidney replacement therapy is challenging. As a result, many patients are either being excluded from kidney replacement therapy or receiving inadequate dialysis. According to the recent study from India, about 200 patients per million population progress to end-stage kidney disease annually. So if you get that numbers to Sri Lanka, this number will be as high as 4,400 end-stage kidney disease patients per year. So that will be accumulating. Therefore, there is a significant gap between CKD burden and the availability of adequate healthcare facilities, including access to kidney replacement therapy. Okay, so this is the actually story of epidemiology of kidney disease in world and Sri Lanka. As you can see, so we are going to get a lot of challenges in future with this rising numbers of diabetes. So that means so CKD. So we have to get ready from beginning. So we'll understand what we have just now and how we are going to work for future with these resources. So if you talked about modalities of kidney replacement therapy, so we have four modalities. One thing is intermittent hemodialysis. We do like twice a week or thrice a week dialysis. Chronic ambulatory peritoneal dialysis or automated peritoneal dialysis. So kidney transplants and kidney conservative therapy. Those are the four modes we have. So intermittent hemodialysis. Let's understand some facts on hemodialysis and other modalities, and then we'll work out what are the indications and how we are going to get them through and get them out from the renal replacement therapy. The intermittent hemodialysis is the most demanding modality. Number of hemodialysis units is about 86 units in Sri Lanka. Number of patients on HD about 6,000. This may be changed. The number of HD machines currently we have 685. Annual hemodialysis mortality is 20%. That means 20 patients on hemodialysis die out of 100 within first year. So that is high case fatality, especially among the comorbid patients. Who are the eligible patients? So basically we select the less comorbid patient for hemodialysis because as you know, it is more complex procedure, involve a lot of hemodynamic changes, blood pressure changes. So so that allow patient to have more complications and unfortunate deaths. So patient have, but still, so we do have to get this treatment for the patients. So patients having fluid overload, we are preferred to put into the hemodialysis, and patients who got poor residual functions, like they have no urine output or very much uremic patients, so they are very much well with the hemodialysis. And then the home condition is not suitable for CAPD. If home condition is suitable, so we prefer CAPD. And then people who are crash landers, so we don't have time to prepare them for CAPD. So those are the most commonly enrolled patient for hemodialysis. So what are the challenges for the hemodialysis? So first and foremost is the number of hemodialysis machines and infrastructure. And interruption of dialysis consumables, especially the needles, tubes, and dialyzers. There are so many hiccups in supply. The cost of care, that is also important because as a country, so we have to mindful about the cost. And trained nursing and supportive staff, that is also a big issue because the people are changing. So that mostly the new people are coming. So then trained staff always moving to the other units or maybe leaving the country. And shortage of nephrology still, so we are having shortages for the country. So that also got a lot for the hemodialysis facility. Okay, let's move to CAPD. CAPD is a home dialysis. So it is a vital modality globally. About 20% new dialysis patients in UK and New Zealand enroll into the CAPD program. In Sri Lanka, however, CAPD is vastly underutilized, with about 800 patients enrolled in national CAPD program. So that means 10% of total kidney replacement patients. So that means we are behind another 10%. So that means we should have the patients more than 1,500 at least in Sri Lanka, according to the numbers. So we have 7 units already in the country, number of patients 800 and number of APD patients 70. So why we have such an underutilization of CAPD? The first is, as you all know, the patient's reluctance to accept the responsibility. So that is always the case in Sri Lanka. The patient management is the patient responsibilities very low, and insufficient trained staff and interruption of supply of dialysis solutions and catheters, as for the consumables. Concern about peritoneal dialysis related infections, this is a major concern, and high catheter failure rates. So that is also, it was a major concern, but now we are well with the Western standards. The limited nephrologist experience and interest in CAPD, that is also a key factor to underutilize CAPD. Nephrologist interest and experience. So that also a main factor for us as well. So what are the challenges for CAPD program? So patient reluctance, shortage of catheters and peritonitis. So those are the main 3 challenges. So let's compare the CAPD versus hemodialysis. What is the better? What is the best for the patient. So I think now when you select the modality for RRT, there's no the best treatment modality. Somebody might say transplant is best. Somebody might say hemodialysis is best. Somebody might say CAPD. I don't think that there's any best treatment modality for the end-stage kidney disease patient. So as you can as you know, so these people are living maybe 20, 30 years with end-stage kidney disease. They may start with CAPD, go for transplant, and fail transplant, go back to hemodialysis, and maybe CAPD, another transplant. So it's like a cycle. So, I mean, we can't pinpoint to say that this is the best treatment. So it depends on the area where you live, the facilities available for the patients from hospital, that hemodialysis facility. So, and whether the established CAPD program is there, so then it will be better one. So what is the transplant program at that area? So whether disease donor, live. So there are so many things to be considered to say that this is the best for the patient. But when you compare CAPD and versus hemodialysis, I feel CAPD is better. So CAPD is home treatment and it avoids frequent hospital visits. It can be selected for patients with poor cardiovascular fitness, or maybe have heart failure, had a past history of MI. So those patients can be selected, and protects residual renal function. That is most important thing, because when you lose residual renal functions, so you are going to get more complication in long run. So that preserving that is very important. And cost wise also, CAPD is cost effective than hemodialysis if you compare with the infrastructure cost as well. Okay, now we have understood about the epidemiology of CKD and end-stage kidney disease. We went through some renal replacement modalities, hemodialysis, CAPD. So let's talk about indications for kidney replacement therapy to proceed with the rest of the talk. Okay, so what are the indications for kidney replacement therapy? So it is an individualized decision. You can't say this is that. So this is individualized decision, and timing and mode of kidney replacement therapy is very important. So whether we are going to select the dialysis or RRT urgently or routinely, because routine dialysis always good outcome. Urgent dialysis may have bad outcome. So always you have to decide the timing. So that, say, if somebody is deciding to dialyze middle of the night, you have to understand the problems you are going to face, and then outcome going to be, then the person who is selected for renal replacement therapy in office hours. So there are so many so many reasons to time the RRT. So that timing and mode is important. And anuria always is not indication for urgent hemodialysis, because so some physicians might think that anuria need urgent hemodialysis or urgent renal replacement therapy or kidney replacement therapy. No, it is not urgent indication for KRT unless other complications like resistant hyperkalemia, pulmonary edema, or patient uremic. So then anuria. So we don't have to rush for the renal replacement therapy or dialysis. We can wait for the next day and get the routine slots for dialysis unless the coexisting complications. And remember, if somebody someone has resistant hyperkalemia, acidosis, pulmonary edema, which is resistant to furosemide, and uremia, those are some of the absolute indication. If these are present, you have to rush for the RRT as soon as possible. So there you can't wait for next day, or you can't wait for the routine slot. You have to somehow get them dialyzed urgently. So those are the indications. So then still I would say, so indications are very much depending on the patient you handle. Some patients we wait for very high values of creatinine and blood urea if patient is not having more complex issues. But some patient we might consider renal replacement therapy or dialysis very early if you think that the progress is going to be very rapid and the recovery is unlikely in next 24 hours. So we start dialysis bit early. So that is like depending on the environment we choose. what is the frequency of kidney replacement therapy? That also depends on the patient's clinical condition. So say somebody, is uremic and going for first dialysis today, so that will be very short dialysis. We might go for a second dialysis tomorrow with a few more hours. So because now the first dialysis, if you do a longer dialysis, they might end up with the disequilibrium syndrome and no. So that, it is also depends on patient clinical condition. More frequently, AKI and uremic patient, we dialyze Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, something like. So that schedule will be important to organize the dialysis slots for the patient. So then otherwise you decide today now go for dialysis, and then we don't have dialysis slots. So we have already taken some patients for dialysis. So then advanced planning of dialysis is important for the dialysis unit. There are smooth functions. So then, and sometimes we might go for daily dialysis, like patients who got hepatic encephalopathy or who are prone to get hepatic encephalopathy, cirrhosis patient, we might do daily dialysis to prevent they are going into hepatic encephalopathy. So sometimes we might dialyze only once, like patient who come with the intoxication, like say lithium or a metformin. So you just do dialysis once, and patient might recover from all, and then you might stop it. Or maybe hyperkalemia due to drug induced, so having near normal renal functions. So we might just do that one dialysis and stop. So that the frequency also depend on the patient clinical condition. And when to stop kidney replacement therapy. So that is also important concept, because sometimes people dialyze very regularly for longer period without any need. So they don't stop, they continue. So so we consume a lot of resources for these patients, and ultimately, so we are blocking some other patients to get into the renal replacement therapy, because so you continue a dialysis on some patient which really not needed. So when renal function stabilize, so it is an indication for stop KRT. So that means you have to monitor the renal function daily basis. You see, so what is the rise of serum creatinine, and so if the rise is not sharp from one day to second day, you might hold the dialysis, or you might stop dialysis for 1 day and wait for the next day. So rather than going for Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, you might skip 1 day and see so how urine output is going to be. What are the numbers of creatinine? So then if numbers are static or plateauing, so you stop it. And if numbers are rising, you consider further dialysis. And when indication for kidney replacement therapy is resolved, like intoxication, so there's no indication, so you can stop it. Or when patient is not tolerating intermittent hemodialysis, that is also indication for stop intermittent hemodialysis and move to a next mode of renal replacement therapy, that is continuous renal replacement therapy. Because otherwise what happens is, so patients are dying on hemodialysis if you choose the wrong person. Okay, then when we move to the next step, that is when to consider continuous therapy. So these are intermittent therapy now. So you are going for an intermittent hemodialysis. So then the continuous therapy. So when patient is hemodynamically unstable, so you consider continuous therapy. Like patients is on inotropic support, or maybe needing respiratory support, which cannot be given in a dialysis unit with the portable ventilator. So those times, so in those patients, you have to consider the ICU and or HDU and continuous therapy. So just to know the continuous modalities, so continuous veno-veno hemofiltration like CVVH, continuous veno-veno hemodialysis, that is CVVHD, continuous veno-veno diafiltration, that is CVVHDF, slow continuous ultrafiltration, that is curve, and sustained low efficiency dialysis, SLED. So SLED is I included into the continuous therapy because a SLED should go on at least 12 hours. So then in our setup, so we cannot afford the SLED in hemodialysis unit in our setup because that will block the other patients' dialysis needs. So then, so possibly, so we are doing it in for the in ICUs only. So we have ICUs having dialysis machine and portable ROs, where you can consider sustained low efficiency dialysis instead of a continuous therapy like 24-hour therapy. If you are out of resources, like if you don't have a dialyzers or tubes for the or fluid for the continuous therapy, you can choose sustained low efficiency dialysis in ICU setup. Okay, so let's move to a next topic. So that is what do you understand by acute and chronic kidney disease? Because that is also very much important topic, mostly physicians, because these patients are getting admitted to the general medical units, and then you refer patient to us. So what is acute and chronic? That is deterioration of renal function from stable baseline value. So say it's acute and chronic, we should have stable baseline values. So mostly the patient has got that value, but some patient whom coming first time might not have the baseline value. And so still we can see the trends of rise of renal function like from one value to next value. Commonly there is a cause for deteriorations, commonly dehydration or drugs or infections. You might be able to figure out what is the cause of this acute deterioration. So if you figure out, so you can imply or you can give the treatment for that as well. Sometimes you get some obstruction, so that you might miss those things if you don't if you don't do the ultrasound. So and kidney replacement therapy depends on complications of AKI, so that it is like AKI. So you wait, you evaluate for the complication. You don't wait, but you evaluate for the complication. If somebody developing complications which need renal replacement therapy, you can get them on dialysis. The prognosis depends on severity of and trigger events and level of baseline kidney function. If the baseline kidney function is far towards the normal, your prognosis is going to be excellent. But if your baseline kidney functions towards the advanced CKD, you might not, the patient might not recover from kidney replacement therapy. They might depend on dialysis. So that is acute chronic kidney disease. So we'll move to another topic. So that is renal transplant. I have separated it from other modalities because it's a separate subject. So a renal transplant program is running well in this country. So we have like 250 to 250-60 patients annually being transplanted in this soil. So mainly live related transplant, but 70% disease donor program is still catching up. But I think I'm satisfied with the numbers now, because it contributes to 30% of total transplant in Sri Lanka. It was very low in few years back, but now we may be building up from disease donor transplant. So what are the challenges for the transplant? As for the other countries, we have organ shortage, so that is common for all countries. And we are still relying on live donation, and a shortage of infrastructure and manpower is a huge issue for us. And also investigation and matching is very poor. We are only going with the ABO compatible transplant. We don't we in the disease donor program, we don't even get the HLA. So that is very poor standard, because we had to match them and get the best person for the transplant. Otherwise, we are going to get a lot of troubles after the transplant. The quality and quantity continuous supply of transplant drugs always is an issue. And shortage of vaccine. So we do need to vaccine these people well before the transplant. So hepatitis and the influenza and pneumococcal, the chicken pox. There are so many vaccines should be completed before transplant. Unfortunately, some of the vaccine is not available in the country. So that is also a drawback for the transplant program. And drug level monitoring facility, that is also very limited in the country. As a result, more patients get acute and chronic rejections. So that is this is very much common than the other countries. Not only rejection, but they develop several infections, because we treat rejections with some more immunosuppressions, and then they develop infections. So as a result, the patients are a short graft survival than other countries. So lack of facility to diagnose cause of infection, that is also is a problem, and increased morbidity and mortality with our patients because of all these shortcomings. So from physician point of view, so what do you know in terms of kidney transplant patient? When you get a patient to your ward with the post-kidney transplant, So first and foremost is optimization of blood pressure. This is not with the other patient because this is a denervated kidney. So there's no way to increase the renal perfusion by the normal people. Like there's no auto regulation at all. So this is a denervated kidney. Unless you get a blood pressure up, you don't get the renal perfusion. It's very parallel to the blood pressure and renal perfusion. So the transplant kidney cannot sustain low blood pressure and make urine. So you have to understand that first. So you optimize blood pressure as soon as possible before they develop acute tubular necrosis. So then if they develop acute tubular necrosis, so you no point of further give fluid because that patient might end up with the pulmonary edema. So plenty of fluid, especially the Hartmann solution, and multi-urine output because they should be polyuric. They normally polyuric. So you have to produce more urine than other people. So it may be more than 1 ml per kg per hour. So that we have to aim. And we might double the dose of steroid if they are hypertensive, and do not introduce any nephrotoxic drugs because you have to get as this patient as CKD. And please do not stop immunosuppression, but they might need some dose adjustment. So you might stop immunosuppression, like stopping MMF when there's a the leukopenia. You can stop it for the short period, or you might stop the tacrolimus if they develop AKI for short period. So, but you might have to consider contact a nephrologist for our opinion for further adjustments, because so you might do first adjustment as soon as you see a patient, but you had to contact and you get some more help from a nephrologist to adjust the immunosuppression, because when you change these drugs, they might end up with the rejection that might be difficult to treat. Okay, so what is the kidney conservative therapy? What do you call the symptomatic management of end-stage kidney disease or renal disease? So palliative care should be important component of end-stage kidney care. Not much difference in the outcome between kidney replacement therapy and kidney conservative therapy in elderly comorbid patients. So, you know, what they say is they might live longer if you select the kidney conservative therapy than kidney replacement therapy. Need to write an advanced directive for all patients with end-stage kidney disease at the clinic level. So that is very easy when they get admitted to the hospital. So what to do, because it's already discussed and written in the notes. The decision may change depending on the circumstances. Sometimes you might have to change this decision if they are coming with some reversible cause of renal failure. So still, if you think that the patient can live longer period with the previously existing kidney function, you might consider the kidney replacement therapy. Even the patient who has given directives of no dialysis when they come to a symptomatic end-stage kidney disease. But that is always depending on the circumstances. So depending on the patient's condition. It is mainly symptomatic management, and you may offer palliative dialysis for symptom controlling. Sometimes you might have to give some dialysis to control the symptoms, like they are dyspneic and they are tachypneic, and so the dialysis might help to keep their breathing better. So you might consider dialysis as a palliative approach. Okay, so that is the end-stage kidney disease, and then RR, KRT, and then indications and those things. And then the Ranga especially asked me to just go through management of complex leptospirosis. I just brief. This is actually the my own experience, but it may subject to some discussions if you want. Now, first of all, a comprehensive assessment of patients. So that will be very important, not the house officer. So maybe senior person has to assess the patients comprehensively. And you need to optimize the blood pressure as soon as possible, because now these patients are kidney is the first organ to affect with the leptospirosis. And so the blood pressure optimization is important to improve the renal perfusion. So second step. So IV fluid if patient does not have features of fluid overload or pulmonary edema. Otherwise, you have to go for noradrenaline, because if you think that the patient has got fluid overload, do not load the patient with fluid if patient is anuric, because when you load patient with fluid, they might end up with the pulmonary edema, they might end up with the pulmonary hemorrhage, they might have to rush for dialysis, so that might cause more harm to the patient. So then you conservative on fluid and add some noradrenaline and improve the blood pressure. And if you think that the cause of this issue is leptospirosis, clinically, so you can't confirm now, no? You give methylprednisolone 1 stat dose, 1 gram, and you build up the blood pressure. If patient is anuric or oliguric, once the blood pressure is built up, you give 1 dose of furosemide, just stat dose, 1 milligrams per kg. Up to that value can be given. But infusions are not going to be useful. So with that, you monitor the urine output, blood pressure, and saturation. You arrange chest X-ray and ECG urgently if the clinical indications are there. Otherwise, you can get the routine investigations. If patient is oliguric, consider hemodialysis, because if your patient is not responding to the stat dose of furosemide, if a blood pressure is built and still a patient is oliguric or anuric, so better put them on intermittent hemodialysis. If patient has got pulmonary hemorrhage, if you think that the patient has got pulmonary hemorrhage, the hemodialysis is needed, you can go for hemodialysis, but otherwise you have to go for a therapeutic plasma exchange. And these people may need further escalation of their treatment from ward to ICU, HCU, because these are the people who are going to get more complications and more complex for the juniors, and also the patient who are going to recover full and get 100% good outcome. So then, because of 2 reasons, you might get them into a next level of care, mostly when the complex leptospirosis. Right, I have finished 35 minutes so far. So I think now I thought of going through some complications of advanced CKD with you, because this part may be mostly done by yourself, and then some knowledge on this area and sharing experience of this area will be important for you for better patient care. So anemia. So anemia is common complication of CKD. It increases morbidity and mortality, significantly affecting quality of life. Iron deficiency and dysregulated iron homeostasis is a major concern. So in Sri Lanka, the first consider iron deficiency. There are most common cause of anemia in CKD. These are the most common cause of anemia in CKD in Sri Lanka. So always consider iron deficiency first, and then go ahead with the treatment accordingly. Because if you don't correct the iron deficiency, so then you might not get good response. So if you correct the iron deficiency, you get good response with the erythropoietin. So the other causes are inadequate erythropoietin production, increased blood loss, hyperparathyroidism, vitamin B12 and folate deficiency, uremia causing bone marrow suppression, those all increased red cell destruction. So those are all cause of anemia in advanced CKD. But remember, consider iron deficiency the first cause of anemia. So treatment, low dose intravenous iron sucrose infusion can be given in most healthcare institutions as outpatient treatments. We just give IV 100 milligrams as outpatient, come to the ward and get it and go. So it won't cause any side effects actually. Only thing is we need to admit them for IVN. We don't keep. So just 1 hour infusion, we discharge the patient home. So can be done in peripheral clinics. So I have done it with this treatment in district hospital when I was at Kurunegala, so without major problems. So they are very cooperative on this treatment. The main side effects of iron sucrose is hypotension, which is rarely developed in slow infusions like IV iron 100 milligrams in 100 ml of saline. So that is why we choose low dose in the places where the resources are poor. And so that is the first treatment. And then erythropoietin and blood transfusion, especially the people who are not going for transplant. If somebody is going for transplant, please discuss with the transplant team about the blood transfusion. And in difficult cases, you might consider the best is the filtered blood, but otherwise at least leukocyte depleted blood can be given for these patients if the patient need a blood transfusion urgently. So that is anemia. And hyperkalemia, I just want to mention that the CKD hyperkalemia is mainly drug related, because they don't develop hyperkalemia only with the diet. So especially the people who are who are on ACE inhibitors or angiotensin receptor blockers, and combined with some spironolactone or eplerenone or finerenone may be the most likely candidate. But what I want to stress is the hyperkalemia is not a good thing. But if you see hyperkalemia, don't rush to stop the ACE inhibitor or receptor blocker, because so that has to be done the last option. The lastly you do that. So you just review the drugs which might not having good benefits like NSAIDs and trimethoprim or something, and assess the patient dietary potassium intake, and you might adjust that. And so you might consider use of diuretics like hydrochlorothiazide or furosemide that might increase the potassium excretion. And you might add some sodium bicarbonate, or you get the venous bicarb level and you optimize the bicarbonate. So those things can be considered before you try to stop the ACE inhibitor receptor blocker, because so what they say is, now when you stop these medications, they are going to die quicker than you keep them on. So if you want to stop it, so you can stop it for the short period, and please restart them after a few weeks when the hyperkalemia is settled. So if you have hyperkalemia or hyperkalemia, both can kill the patient. So that we have to be very much mindful about the one end of hypokalemia and other end of hyperkalemia. One thing about hyperkalemia is people are going to town of stopping the fruits and vegetables in the patients having CKD and hyperkalemia, but that will be the one least contributor for the hyperkalemia. So what they say is the absorbable potassium in plant-based foods are about 50%, so half. But if you consider animal-based foods or mainly processed food, you get more absorbable potassium that might contribute more potassium bulk to the patients than plant and foods. So you have to assess the patient's diet, and you have to advise them rather than just jumping into saying that don't eat fruit, don't eat vegetables, and might not be the cause of hyperkalemia in that patient. Hyperuricemia, so no evidence of treatment unless they have gout or renal stones, and they should not be on any allopurinol or the fibrosostat if they have high values of uric acid, unless patient has got existing gout or renal stones. So vitamin D, I will stay a little bit on vitamin D deficiency and calcium carbonate 1-alpha and vitamin D, because I think this area is not explored well in our population. So I just give some facts you to think about this. In adult population, 35% of adults in United States are vitamin D deficient. Whereas over 80% of adults in Pakistan, India, Bangladesh are vitamin D deficient. United States, 61% of elderly population is vitamin D deficient, whereas 90% in Turkey, 96% in India, 72% in Pakistan, and 67% in Iran are deficient. So that is elderly people. In Sri Lanka, situation is much similar to the neighboring countries. So published literature says about 80% of people having vitamin D deficient. So what is vitamin D sufficiency and deficiency? So vitamin D deficiency is less than 30. So mild, moderate, and severe. So mild less than up to 20, moderate up to 10, if severe is less than 10. So you can grade the severity: severe, moderate, and mild. So vitamin D compounds. So you understand. So what is vitamin D? So there's a knowledge gap. So understanding vitamin D. Vitamin D compounds can be classified as nutritional or active depending on whether they directly activate the vitamin D receptors. So active compounds are also called vitamin D receptor activators. vitamin D receptor activators. Those are the active ones. So calcitriol is the naturally occurring vitamin D receptor activator, but many synthetic analogs are available like alpha calcidol, maxacalcidol, pericalcidol, and so on and so on. So active 1,25 dihydroxy vitamin D increases intestinal calcium absorption and bone resorption. Remember, they resorb bone, decrease in renal excretion of calcium and phosphate. The main activity of a vitamin D, active vitamin D, or a vitamin D receptor activator, is one thing is intestinal calcium absorption and bone resorption and decrease in renal excretion of calcium and phosphate, allowing more calcium in the blood. So that is the main task of vitamin D. So you allow more serum calcium in the blood as a result of active vitamin D. Instead of vitamin D deficiency, what happens? So when vitamin D is low, parathyroid hormone production is upregulated. It increases the parathyroid hormone. This secondary what you call the secondary hyperparathyroidism leads to high phosphaturia. So it will increase more, it will excrete more phosphate and accelerate bone demineralization, which can further result in osteomalacia, osteoporosis in adult, and osteomalacia and rickets in general. So you understand? So vitamin D deficiency can result secondary hyperparathyroidism, which leads to the bone resorption and produce more phosphate and blood calcium into the blood, and also it will allow more phosphate excretion from the kidney. So as a result, you get osteomalacia, osteoporosis in adult, and osteomalacia and rickets in children. The 20 minutes sunshine daily with over 40% skin exposure is required to prevent vitamin D. So if somebody is getting adequate amount of exposure to sun, will produce enough vitamin D. So, but remember, it is about 40% of exposure is needed to produce adequate amount of vitamin D, especially. So you have to stay in sunlight for 20-30 minutes, maybe more longer exposure for the dark people. So 40 to 60% of patients with CKD have calcium intake of less than 800, because I had to move to now calcium because I had to correlate both together at the end. So then about half of the CKD patients have a calcium intake of less than 800. Calcium intake can increase dramatically with calcium containing phosphate binders. When you give calcium containing phosphate binders, you can increase the calcium intake. Initial supplementation of 8 weeks of vitamin D, either 5,000 or 60,000 weekly, can be considered in deficiency cases. I'll come to that later. So, so what you have to maintain is vitamin D level exceeding 30. So okay. So we'll come to the KDIGO guidelines on CKD MBD. The KDIGO CKD MBD guidelines published in 2017 suggest that the vitamin D deficiency and insufficiency should be treated like a general population. So then when somebody is having low vitamin D, having CKD, should be treated as normal population. So calcitriol and vitamin D receptor activator, that is 1-alpha and calcitriol and so the vitamin D receptor activator should be reserved for the people with stage 4-5 and having severe hyperparathyroidism. Though the optimal parathyroid hormone levels or target is not known in patients without patients or pre-dialysis patients. But now what they say is, so this active vitamin D should be limited for the people having stage 3, 4, and 5 having severe hyperparathyroidism. How we are going to diagnose hyperparathyroidism? You have to do the PTH, or maybe with symptoms, or maybe with high alkaline phosphatase. So, you know, that is a clinical judgment. What are the problems in our country? We have a poor diet with vitamin D and little exposure to sunlight. So that is mostly correct. So poor diet, which contain less vitamin D, and very low exposure to sunlight. About 80% of general population is deficient of or insufficient of vitamin C. That is being published in literature. We must assume that most our patients, or maybe almost or most our patients with CKD, have chronic vitamin D insufficiency or deficiency. So secondary hyperparathyroidism is likely due to hypocalcemia rather than hypophosphatemia. So usually, when you get a secondary hyperparathyroidism, in our case, it can produce more hypocalcemia than hyperphosphatemia because our diet is poor in phosphate. So if our diet is poor in phosphate, you might not see hypophosphatemia, but you see hypocalcemia. So alpha calcitriol replacement will worsen the CKD mineral bone disease by increasing risk of bone resorption, hypercalcemia, and vascular calcification, further depleting body's vitamin D. So that statement is very much you should understand, because when you give vitamin D receptor activators, this will worsen the CKD MBD because it will allow more bone resorption, which produce more calcium to the blood and more phosphate, and so that can cause vascular calcification. And not only that, so when you give vitamin D, you can deplete the body's vitamin D stores. So vitamin D is stored in the liver with which can be activated from 1 and 25 hydrolysation to active form when necessary. So you store it. When necessary, you activate the vitamin D and utilize. When you give vitamin D receptor activators, so that won't produce any storage because that is active one. It will give its action, but it won't be able to get stored in the body. So you can't have any vitamin D store at body, but you have action of active vitamin D, which resorb bone and produce more calcium into the blood. So when you have more calcium or hypercalcemia, it can cause vascular calcification, which is ultimately end up with the vascular complication like STEMI, non-STEMI, stroke, and calciphylaxis and peripheral vascular disease. So I think all patients should be evaluated biannually for the calcium, phosphate, and alkaline phosphatase, PTH, vitamin D level. If you can do it, so perfect. All CKD patients should have vitamin D replacement with cholecalciferol, not 1-alpha, please. So it is cholecalciferol, that is the plant ones. Hypocalcemia or hypophosphatemia, hypocalcemic or hyperphosphatemic patients need calcium carbonate as a calcium supplement, which also can be utilized as a phosphate binder. So when you give calcium carbonate, so that will replace the calcium to the body, so that will correct the hypocalcemia, and yet that can be used as a phosphate binder, so that will reduce the phosphate absorption from the gut. Knowing vitamin D levels make it easier to decide on dosing. So vascular calcification is low possibility with normal or low serum phosphate and calcium. If you have low serum phosphate and low serum calcium, vascular calcification is unlikely. So active vitamin D analogs should only be considered in patients with high alkaline phosphatase or high PTH or stage 4 and 5 if you think that the hyperdynamic bone disease is there. These should also be low dose, preferably interrupted, that is 3 times a week or twice a week rather than daily basis, because when you give daily basis, you have more bone resorption and causing more trouble. So you have to have interrupted maybe Monday, Wednesday, Friday, or Monday, Friday, or like very infrequent dose of vitamin D, active vitamin D. We must encourage patients to expose sunlight as much as they can, at least to produce some vitamin D from sunlight. All ST and CAPD patients can receive high dose of vitamin D because so that they need to have stores of vitamin D. And other CKD patient can have maintenance dose of vitamin D like 1,000 to 1,000 or maybe 5,000 weekly or maybe high dose 2 monthly or something. So depending on the unit protocols. So weekly, monthly doses are more cost effective than daily doses. So we'll move to a next complication, acidosis and fluid overload. So mostly seen in advanced CKD, investigations are useful like doing a venous bicarbonate because we might have to do that. So good nutrition. And the one thing you need to know is if somebody is taking less animal products on more plants-based diet, so their production of acid load is very low. So if somebody is eating a lot of meat and fish, they produce more acid. So our diet is rich in plants. So then development of acidosis in our CKD patient is very late or very advanced CKD only they develop a acidosis. So that also need to be keep in your mind, because I have seen some people introduce sodium bicarbonate very early in the CKD, like CKD 3B4. So I don't think there are real need of sodium bicarbonate, because when you add sodium bicarbonate, because bicarbonate is good but sodium is bad, so it add more salt to the body, it keep more fluid, so that cause fluid overload, it can cause resistant hypertension, so that also be a bad thing for the CKD patient. So remember, so that diet always guide you what to do. If they are very much poor in meat, so the chance of getting acidosis is low. So introduction of sodium bicarbonate is late. But if somebody is taking a very high protein intake, yes, you might consider. So good nutrition, oral sodium bicarbonate will be useful in advanced CKD, and fluid restriction and use of diuretics, because you have to use furosemide. Otherwise you might not allow to clear this one. So that is mainstay of treatment. And also, if you are going to consider starting sodium bicarbonate, you might combine with low dose furosemide to excrete sodium coming from the sodium bicarbonate. And KRT is next option. The last topic is diet and CKD. Advise people with CKD to adopt a healthy and diverse diet with high consumption of plant-based foods compared to animal-based food, because plant-based foods, protein is much better than the animal-based food. Allow lower consumption of ultra-processed foods and low sodium intake. So that is 2 grams of sodium or less than 5 grams of sodium chloride. And when you talk about the protein intake, daily protein intake in adults with CKD with the recommended range of 0.8 grams per kg body weight day, particularly avoiding excess protein intake, that is more than 1.3, so which is good for the dialysis patient. Clinicians should advise people with CKD not to confuse grams of protein per day with the weight of the food in grams. So that is also need to understand, because when you say 100 grams of meat contain only 25 grams of protein. So that grams of meat is not equals to a gram of protein. So that is 1/4 of uh, uh, 1/4 of protein. So if you have 100 grams of meat, you have only 25 grams of protein. So that you should not get confused, because otherwise you will have small pieces of meat and fish for the CKD patient, and they don't get any protein at the end. So please remember, so the grams of protein is not equals to the grams of meat or fish. So this is like a rough guidance of amount of protein in the these animal proteins. Like egg contains 6 to 8 grams of protein, and the other things you can see. The plants also contribute to some protein intake for the patient, like legumes, dried beans, 7 to 10 grams of protein for the 100 or a half cup of cooked legumes and beans. Whole grains and starchy vegetables, breads, so also can contribute some to the protein intake. So a plant-based diet is having good anti-inflammatory nutrient, fibers, phytochemicals. So this has been shown to reduce proteinuria and decrease metabolic acidosis as well. So ultra-processed fluid should be avoid as much as you can, like sweet beverages, fast foods, frozen meals, chips, candy, and pastries are high in salt, sugar, and fat, and low in nutrition value. They promote inflammation, which contribute to worsening of kidney functions. So this is what I discussed. So I have discussed actually these parts, not this part. I think this part is most important part than this part for you. Locating people with risk of CKD and diagnosis the injury and prevent progression. So that part I have not touched. I have done this part. We'll do it in future. So thank you very much for listening.
Dr. Can you
All right.
put the share? Okay, right. Thank you. Hope you all can see the uh, CPD slide. And I'll be sharing the link in the chat box as well. You can either fill up the form using the link or using the QR code. In the meantime, shall we take up the questions, Dr. Naga?
Yes, yes, sure.
Yeah, yeah. Uh, First one is what is your recommendation for antibiotics dose adjustments in CAPD? Most of the time, there's no clear guidelines. Should we go by the EGFR or serum concentration where possible, or should it be considered as a variety of CRRT where adjustments are not much necessary?
It's a good question. I think now when you talk about the patients on RRT, you have to take that the GFR less than 10. So that is like a bottom line. So hemodialysis, we see you have to see these drugs are excretable in dialysis or not. So we need that knowledge. And then for the CRRT, actually, you have to increase the dose of antibiotics because so that will be excreted due to this long filtration. So we might have to go for a normal dose or high dose in CRRT until the CRRT is on. So when you move to hemodialysis, so if the drug is dialysable, we tend to give it after dialysis, and we have to adjust the dose according to the patient's GFR. And for the CAPD, also same. CAPD mainly we use for intraperitoneal antibiotics for the peritonitis, but any other indications, you have to go with the GFR less than 10 and adjust the antibiotic dose. So normally when they have CKD, your drug doses are same, but the frequency is less. So say somebody is on 6 hourly, you might do it 8 hourly. Somebody is on 8 hourly, you might do it twice a day, or maybe daily, or maybe every other day. Something like vancomycin, we give every third day. So, but if you can monitor the drug levels, so vancomycin drug level can be checked, can be done in MRI. So if you can get the vancomycin level, so you can do the best for the patient. So you keep the vancomycin level about 15, like you can have a range of 10 to 20. So if you have facility, but otherwise you might have to do it like every third day vancomycins.
There's a question on the second one, but that question is beyond the scope of this lecture. It says how to differentiate the acute cyclosporine toxicity from acute graft rejection without a biopsy. So,
I think the best way to do that is to get the cyclosporin level. So if
yeah,
your cyclosporin level is high, you have to consider that first. But anyway, biopsy is important. Still, you might miss some other causes of graft dysfunction. It's a compulsory to do biopsy, but cyclosporin level will indicate you the most likely cause.
what are the steps that we can be taken to prevent to HD line infections?
Yeah, that is also a very good question. So line infections are very common among the dialysis patients. So temporal line infections are most common than tunnel line infection. So tunnel line infection is much better in terms of line infections because it has a less chance of getting infected. So whatever it is, so now first of all, it depends on the operator. So how operator does the line insertion. So whether the operator comply with all these aseptic method to do the line infection, because otherwise it might get infected during the time of insertion. The later, so it might get infected from the exit or from the inside the catheter, because when you dialyze, so dialysis team can introduce infection to the catheter, because if they contaminate the dialysis tubings or solutions, they might end up with the line infection. There are so many things happening during insertion and during use. So now in our case, so if somebody is going for long-term dialysis, we only go for tunnel lines, not for temporal line, because tunnel line has got much good resistance to infection than temporal lines. If we are going for temporal lines, we had to remove that during the time period. So for the femoral lines, we only so the duration is 5 to 7 days. So commonly remove that line day 5 or not more than 7 days. For the necklines, so 2 to 3 weeks. That is the time given for the necklines. So you have to remove the neckline, and you have to sort a next best access with that. So if you are going with the temper line for dialysis, but you have to get the tunnel line and remove the temper line within first 2 weeks. So that will prevent the line infection mostly. And then the education of staff about the handling of the catheter. So it can be infected from the exit or inside during the dialysis procedure. So and patient hygiene also important. So because sometimes some patients are colonized with MRSA. Those patients are likely to get infected with MRSA in due course. Now in our dialysis center, we give gentamicin line lock. So line locks are actually important in terms of prevention of dialysis-related infection, catheter-related infection. In other countries, they have Duralock, so that contain antibiotics plus citrate. So, but we don't have that solution because that is expensive. So we use only heparin for the line lock. That might not enough to prevent line infection. You know, in poor resource setting, you might use gentamicin with heparin for the line lock in prevention of line infections. So that is some units practice that. So it all depend on the unit protocols. But we do give gentamicin line locks in our hemodialysis patients.
What is the optimal blood pressure to aim for AKI and leptospirosis?
So yes, so that is not there's no hard and fast rule saying that this is the optimal blood pressure. What my work is, so I will optimize blood pressure until the patient produce urine. So urine means up to 1 ml per kg per hour. So that is my target. So some patient achieve this target with 100 milligrams of 100 millimeters of Hg blood pressure. Some patient might need 140. So a younger patient achieve this target in low blood pressures, but older patients or patients who got other comorbid conditions need higher blood pressure. So there's no the value to say this is the blood pressure you need to achieve, but the blood pressure need to increase the renal perfusion, increase the urine output will be the target you should achieve first. Sometimes you might not get adequate amount of urine output. So in that case, if somebody is going for dialysis or intermittent hemodialysis, so having a map of 80 at least will be very useful, because otherwise they might end up with the hypotension during dialysis.
I think we have answered this question. What are the dietary advice for the patients who underwent AKI on CKD?
Yeah, it is like now mainly, so what we should address is the amount of protein intake if they are on dialysis, because dialysis the dialysis need much more protein intake, because that will lose a lot of protein, especially CAPD, but hemodialysis also. So then you have to have something close to 1.3 grams of kg protein intake. But so that is the change you are going to have during that particular period. If somebody is on long-term dialysis, you have to continue keep the protein intake higher to achieve the protein energy malnutrition. And then you have to assess their potassium, because you don't address everybody to reduce potassium because they have normal potassium. Sometimes some patients are having normal potassium, but you advise on low fruits or low vegetables. So those things are actually not scientific. So, so you should not advise these things unless you see abnormal results. So if somebody is having normal potassium, you advise on normal diet. If somebody is having high potassium, only you can consider potassium restriction. And fluid restriction is important if they are oliguric. If they are oliguric, you better restrict the fluid because hypervolemia always cause more complication than hypovolemia. So if you can't aim for euvolemic, you keep a little hypovolemic than hypervolemic. Hypovolemia cause problems.
In leptospirosis, if the patient is having pulmonary hemorrhage, is it only stat doses methylprednisolone or 3 doses?
Yeah, it is a good question because now we are we are not having a lot of evidence on this approach. These are my personal experience. Now there are recommendations of methylprednisolone 3 doses and oral prednisolone up to 7 days in some guidelines. But what I notice is now when you go beyond the pulmonary hemorrhage, the next common complication is infections, and patients are getting recurrent or more infections, and they might die of immunosuppression related issues once they survive from lung hemorrhage. Now, what we have to understand is why we give methylprednisolone. So, is it for immunomodulation or immunosuppression? It is not for immunosuppression. It is for immunomodulation. If you are going for immunomodulation, do you really need a longer duration of methylprednisolone? Because now when you give methylprednisolone 1 gram, so it's a high dose. So that will mostly stop some of these unwanted body's activity that might damage the own organs like the blood, the lungs. So now, see, this is my argument. So in any complex leptospirosis, giving 1 dose of methylprednisolone is very rational to modulate the immunological or immune pace or immunological activity that will damage the body's own cells. But if you go for more methylprednisolone, that always cause trouble. So you have to, I think, assess the patient regularly, daily basis, and consider giving more prednisolone. So maybe a second and third dose can be given in patients who are having actually severe lung hemorrhages, which are resistant for the treatment. So, otherwise, you might stay on just 1 dose, maybe 2 dose. I think now the rather than telling you that this is the number of doses, you assess the patient and decide on the methylprednisolone doses because it always causes trouble at the end because of infections. I think people who manage these complex CKD patient, a leptospirosis patient might have that experience. The people who work in the ICU might have this experience of increased incidence of infections after the recovery of lung hemorrhage. So that has to be considered when you thinking of immunosuppressions.
What is the threshold for hemoglobin level for blood transfusion in CKD?
Yes. I think there is no hard and fast rule saying that this is the value you should keep. So it all depends on the patient's symptoms or well-being. So if somebody is tolerating hemoglobin of 7, so if patient is going for transplant, I wouldn't consider blood transfusion because our main concerns when you get a transplant is rejections and when you have blood transfusion, they are going to have very high chance of getting rejections. So that I don't want to get sensitization of my patients because of this issue. So if somebody is stable, if he is going for transplant, I think you have to have a discussion with the transplant team about the blood transfusion. But if somebody doesn't have transplant plan, if somebody come with non-STEMI or STEMI, even with the hemoglobin 8, I might give some blood transfusion to correct the hemoglobin to 10 because that might be the most important step in terms of improving the oxygenation of the organs. So that has to be decided the individual grounds depending on the patient's presentation. If somebody is coming with the shortness of breath, and features of anemia. If somebody is having hemoglobin 7.5, you give some blood transfusion. But remember that if he is going for transplant, you might have to consider either. Sometimes you might have to ask for a filtered blood. So if that is there, you might give blood transfusion even with the high values. But if filtered blood is not available, the next best is the leukocyte depleted. But leukocyte depletion is not 100%, so that you allow some sensitization. So case by case you have to decide. But if somebody is not going for transplant, so you decide depending on the indication you give, indication patient coming for treatment.
I think we have answered this question, when to start calcium carbonate and alpha calcitonate for in CKD patients.
Yeah, it is like, as I said, so calcium carbonate can be utilized as a calcium supplement for these patients. Now, as I said, now calcium, what is the daily calcium requirement? It is about 800 to 1000 milligrams per day. So, is your patient taking that amount of calcium? Yes, you don't have to consider calcium. No, you had to consider calcium replacement, because now calcium deficiency is common. As I can remember, about 50 to 60% of patients CKD3 onwards have taking calcium less than 600. So those patients actually need calcium replacement. Now, if you want to give calcium replacement, you give calcium carbonate. And also you can consider calcium carbonate as a phosphate binder. So then it's a dual action. So if somebody is having low calcium and high phosphate, you can give calcium carbonate with meals. So that will bind to the phosphate and which prevent absorption of phosphate, and that will handle the hyperphosphatemia. And some calcium will be absorbed, and that will handle the hypocalcemia as well. So that is a dual action. If somebody is having only hypocalcemia, you can give calcium carbonate without meals, because you don't want to have calcium carbonate with meals, because calcium absorption is not great with the calcium in the meals. So that can be considered. So calcium can be given for the CKD patient for the nutrition or for the bone health. So most of our elderly patients, they have negative calcium balance. They have poor bones, and calcium carbonate will be useful to supplement calcium for the patient. But it is not the straightforward for the 1 alpha. As I mentioned, 1 alpha or a alpha calcidol or a calcitriol is a active vitamin D receptor activator. So that will resorb bone and get more calcium to the bloodstream. So that you should not do, because that will cause more calcification and resorption of bone and causing bone pain and osteoporosis and osteomalacia and all sort of issues. Because the main aim of the main task of active vitamin D is to keep blood calcium normal or high. So that we should not do. So then 1 alpha should be introduced when a patient has got hyperdynamic bone disease to suppress PTH activity or secondary hyperparathyroidism. So ideally you have to have PTH, but you might not get the PTH. You might go with the alkaline phosphatase, because alkaline phosphatase is high in high bone turnover. But alkaline phosphatase values are within normal limits. Most our patient, simply because most patients are on 1 alpha. So then it suppresses the alkaline phosphatase and it is normal. So that also cannot be assessed in CKD patient, because most of CKD patient on 1 alpha. So best is to consider vitamin D, that is cholecalciferol, and then calcium carbonate as calcium supplement, and assess the patient's symptoms, like if they have bone pain, and if your alkaline phosphatase is high, or if your PTH is high, or patient is in advanced CKD, you can consider low dose calcitriol, that is interrupted dose, not the daily basis, maybe twice or thrice a week. So that will not do many harms, even if you don't know the PTH level.
Do you think cutting down dietary potassium as much as possible would be beneficial to compensate for drug-induced hyperkalemia, whereas stopping certain drugs, such drugs, is not possible?
I think what evidence says is keeping ACE inhibitor, receptor blocker, mineralocorticoid receptor agonist are useful than cutting down the diet.
Right.
So because these are all modify the outcome of the patients. So if you stop these drugs, they might have premature deaths. So recommendation is to consider dietary adjustment than stopping drugs.
Are there any advantages of lanthanum over calcium carbonate in CKD MBD?
Yeah, lanthanum, one
Mm.
thing is it's a metal, and then second thing is it is not very palatable, and thing is it is expensive. So now previously people thought the lanthanum and sevelamer is better in terms of phosphate binder, but now what current evidence says is most these patients are hypocalcemic, or they are taking low calcium intake. So then giving lanthanum and sevelamer will add one thing is pill burden, because that will be additional or two, three, four drugs. Second, it is not, it is distaste. And third, so that the calcium levels will be low. So and also expensive. So in all, so the current recommendation not give more weight to the lanthanum and sevelamer. What they say is go for calcium-based phosphate binders if they have normal calcium or low calcium.
When a patient is having AKI and is on intermittent hemodialysis, when and how do you decide on giving furosemide? Does furosemide alter the natural cause of AKI?
No, furosemide doesn't alter the natural course of AKI. So it gives false reassurance of, or you might mislead giving furosemide because it produces more urine, but the creatinine and blood urea will be rising and patient might end up the complication. So better not consider furosemide in all cases. But sometimes you might have to consider furosemide. Say somebody is having rising creatinine and oliguria, fluid overload, and we don't know what to do. So, giving one dose of furosemide is very useful in that sense, because if patient produce more urine, you can wait for the next day to decide on treatment. If patient is not producing any urine, you might have to consider dialysis depending on the patient's complications. Like, say somebody is having hyperkalemia, acidosis, and then rising creatinine, fluid overload. You don't know what to do now. Give a dose of furosemide and see what is the response. If response is good, so that means we know that the patient has got recoverable or normal kidney tissues or glomeruli, which might allow to clear some of these things and might improve the patient's outcome. So and also, so you can wait until next day, not to go for renal replacement therapy, because he's producing urine, it might clear some of these unwanted things. So if patient is not producing urine, that is easy. So that means you are not going to get anything better tomorrow. Why don't you do something today if facilities are available?
Right. When to start sodium bicarbonate? Usually in our practice, we do a VBG and check whether there's low bicarbonate and then decide to start on sodium bicarbonate.
So that is the perfect way, if anything
Mhm.
less than 22. But
Mhm.
remember, when you check VBG, you have to be very mindful about the duration of the sample taking sample. So what happened is mostly the when your patient go to lab, it get the blood and transport to some other center for bicarb analysis. You never do that, because when you send the sample for the lab, so it is invariably low, because bicarb is not a stable compound and which can degrade, and you might see a low values when you reach when the blood stay more than 1 hour. If you want to really check the real bicarb value, you have to advise the patient to go to a lab which does the bicarb there. So then only you get the correct value. Otherwise, it gives you always low values. And in my practice, because our diet is such that having low amount of protein intake, you might not see acidosis until they have advanced like GFR less
CKD.
than 20. So you might have to wait. And also, as I said, now sodium is always a problem when you give sodium bicarbonate, because we don't have potassium bicarbonate, we have only sodium bicarbonate. And so that will give more sodium to the body. So that causes more fluid overload, hypertension, and you might need to add more drugs for the blood pressure control. So all in all, it might not be very much good drug for our patient. If now other option is calcium carbonate, because calcium carbonate also can be utilized for the correction of acidosis. The carbonate can be metabolized to bicarbonate and produce bicarbonate in the body. So it is not like effective as sodium bicarbonate in correction of acidosis, but it might be a good idea to consider first. And then you can add the sodium bicarbonate. We have low values of bicarbonate.
Usually, when giving iron sucrose, we give 500 ml divided among 3 days. Do we give this infusion over 1 hour as well? Also, blood glucose also tends to rise during this time. Do we need to control this with insulin or will follow up later?
Yes, it's a good question because that is the practice almost all in the country.
Yes.
What I did was actually now this practice. So you have to admit patient for 3 days. You have to keep the patient for 3 days, and you have to give a high dose of iron sucrose. So that is 500 milligrams of iron sucrose within 3 days. And what is the problem of iron sucrose is one thing is the high doses can cause blood pressure drops, and second in patients having infection might worsen the infection. Not only that, the baddest outcome is iron sucrose can worsen the fluid overload, and pulmonary edema, heart failure can be worsened. So
Yes.
then all complications going to happen in high dose. What I did was I just consider a low dose, that is 100 milligrams of IV iron in 100 ml of normal saline, and just give 1 hour infusion. And then if there's no any issue, patient can be discharged. And then patient is coming for the next clinic for the 1 month time. And then when they come to the clinic, they come to our ward and get the IV iron second dose and go. So that way you can give IV iron very regularly, but not frequent as days, maybe month. And then so that will allow smoother correction of iron stores in the body rather than rushing for it. Anyway, so if somebody is having low hemoglobin, you might have to combine with the erythropoietin. So that erythropoietin will get the blood hemoglobin up faster than IV iron. So then IV iron will allow low erythropoietin doses, and may later, so you can stop erythropoietin when the iron stores are completed. So that way, so you can manage most patients as outpatient. So I have done I think these IV iron infusion in peripheral clinics like district hospitals, where these patients are coming to them A&E and get the IV infusion over 1 hour and go home. So then next infusion in 1 month time. So if somebody is having very low ferritin, if he's not having fluid overload, yes, of course, you can admit the patient to the ward and give high dose of IV iron. That is up to 500. But if somebody is not having such low values and if not willing to stay at ward, you can do the low dose and send the patient home and get them down the next visit for the next dose.
Right. When do we start erythropoietin and which GFR would that be?
So now there's no GFR value. So first you consider iron deficiency. That is the most likely diagnosis for your patient. And consider hemoglobin. If somebody is having hemoglobin of 9, and if you think that the patient is having iron deficiency, start with oral ferrous sulfate and wait for 1 month. So you reassess the patient. If hemoglobin is improved and no change, you continue iron for 3 to 6 months until the iron depletion is completed. Say if the same patient coming back after 1 month, hemoglobin is not has gone up. So that means so two things. One thing is still he may be having iron deficiency or he may be having erythropoietin deficiency. How we are going to check that? Better to have ferritin values. If ferritin value is low, you know that the patient has still iron deficiency. You might continue oral ferrous sulfate or you might go for a IV iron. If ferritin is normal or high, you think that the patient is not having absolute iron deficiency. You may have a relative iron deficiency. You add erythropoietin and continue iron supplements, maybe oral or IV. And so when the hemoglobin is up, you might reduce the dose of erythropoietin. So I think now erythropoietin is being used more frequently than you should. And these patients, sometimes you might continue erythropoietin when hemoglobin is 13. So I have seen people are on erythropoietin because the dose adjustment and assessment of patient is not at all happening. Because you start erythropoietin, you continue. No, that is not the right way. You start erythropoietin and assess the patient's hemoglobin. And also you get the patient's ferritin value. Because now all the other investigations are useful to detect the iron deficiency, but ferritin is the one which gives you the prognostic value. So if ferritin is low, you are likely to get the hemoglobin up when you give iron supplements. And if ferritin is high, you are not very confident of a correction of anemia only with iron. You have to combine it erythropoietin. What happens is when you start erythropoietin and iron, so you increase the hemoglobin. So then you reduce the erythropoietin to keep the hemoglobin value you required. For the CKD patient, I think so hemoglobin of 10.5 to 11 is more than enough, and don't go more than that, because as you can remember, when your hemoglobin is higher in CKD patient, they are going to get one thing is STEMI, non-STEMI, stroke, and all vascular events are higher when hemoglobin less more than 12. So then keep it with 10 to 12. So that means I think I keep it 10 to 10.5 to 11. So that is the target we can reach easily. And keep the lowest amount of erythropoietin dose. So maybe 2 weekly, maybe 3 weekly, 1 monthly, once a week, some patients. And you had to consider iron deficiency in any point. He may be having normal or high ferritin when you start erythropoietin, but after 3-4 months, your ferritin may be low, which patient needs some IV iron or oral iron to complete the or to fill the iron deficiency. So then only you can continue the low dose erythropoietin. Otherwise, when you start erythropoietin at 3 months, you have to double the erythropoietin dose. So that is because you have not considered iron deficiency coexisting. So you have to always consider iron deficiency any point during the erythropoietin injection, maybe beginning or maybe middle or maybe later. So you always consider iron deficiency and correct it. So then you can utilize the lowest dose of the erythropoietin, which may be cost effective for the country and also convenient for the patient.
We have almost at 11 o'clock. So
10
we have,
o'clock.
I think, another 10 or 11 questions. Are we good to go, Dr. Nalaka?
No, I don't have any problems. You can continue.
Okay, sure. Right. In the patients with early stage of CKD and low ferritin, can we manage with oral iron or do we have to go for IV benefit?
No. You can always start with oral line first. Go for 3 month trial. If patient is not, so a few things can happen. One thing is patient tolerate and hemoglobin come up, no worries. Patient might not tolerate, patient might develop constipation, and then GORD symptoms and all. Patient is very less compliant on iron, so you stop oral iron and go for IV iron. Otherwise, a patient is not responding at all, you always consider IV iron. If ferritin value is not high, sometimes ferritin value may be high, so then going for IV iron is not the best for the moment. You start with erythropoietin and let the ferritin value to come down, and then you consider IV iron later.
What are the safe painkillers that we can use in CKD patients?
Yes, so that is also a good question. There's no kind of safe painkiller. So any painkiller has its own complications. Paracetamol can be used as a bottom line. Paracetamol or Panadine and Tramadol, so those are okay. Even NSAIDs can be considered in early CKD, provided that. So there are a few things you should address. One thing is patient should be not dehydrated. Patient hydration is patient is should not having ongoing fluid losses like diarrhea and vomiting. So those circumstances you should not consider in NSAID. And also, if you can stop ACE inhibitor receptor blocker when you start in NSAIDs. You can go for 3-4 days. Once the pain is settled, you might stop and restart on the ACE inhibitor receptor blocker which we have stopped, because NSAIDs can be given in early CKD provided that patient is not having dehydration and no possibility of ongoing volume losses when you start. So you have to make sure that in that case, so you can give few days, 3-4 days of NSAIDs, make sure that the patient get increased hydration. So don't consider very potent one like aciclovir and all. You can go for like etocozips, celecozips, or ibuprofen, like low efficiency drugs, and low dose and short period, provided that patient is having good hydration. So allow patient to drink plenty of water. So that will be safer in your patient, but don't do these things in advanced CKD, but early CKD you can. And advanced CKD, the options are paracetamol, tramadol, and maybe something like colchicine for the gout, and the intravenous things like morphine and all.
Why is it very common to see hypophosphatemia in patients who are undergoing hemodialysis?
Yeah. So it is because the phosphate clearance during the hemodialysis is poor. Even CAPD is poor. So that is why, and also our frequency of dialysis is very low. So we are doing once a week dialysis or twice a week dialysis. We are not getting thrice a week dialysis, which is recommended by the guidelines. So we cannot reach to that because of poor resources. So we are very much limited dialysis facility. So that dialysis clearance is less. And kidney reserve kidney function is not there, means so you are not going to get phosphate clearance at all. So this is not a problem with the this is a problem actually pre-dialysis and dialysis patient. So but stage 3, 4, it is not a real problem because fortunately our diet is poor in phosphate. So so the accumulation of phosphate is unlikely to see on in these patients in these stages. So this is actually a pre-dialysis and dialysis issue, hypophosphatemia, and also use of 1-alpha. So that also important contributor for the increased phosphate, because as you can remember, 1-alpha or active vitamin D increase the absorption of calcium and phosphate. So then when you give 1-alpha, so that will produce more calcium and phosphate to the blood. So it will give high values of phosphate. So you have to stop or cut down the frequency of 1-alpha if your patient is having hypophosphatemia.
Is it safe to use daily 1,000 international unit of vitamin D for a healthy individual?
I think yes. If you know the vitamin D levels, you are very well with that, because if I think as far as I can remember, so high values are very uncommon. So if you want to consider vitamin D, I think elderly people, I don't think any restrictions for that. But if you are really want to manage the patients, you can ask patient do vitamin D levels and see what is the vitamin D value. If what they say is more than 100 is the toxic values, 30 to 100 is the normal value. If anything less than 30, you have to do a replacement. So that means you have to give high doses. If it's between 30 to 100, you can continue the what do you call the maintenance dose. So maintenance dose, what they recommend is 400 to 1,000 international units daily. So that is the recommended dose. So you can continue that, but that may be more expensive. As I mentioned, so this is can be stored in the body. You can give little higher doses, not exceeding 5,000 per week. So that can be stored in the liver, so that we can go for a weekly basis, but not more than 5,000 for the normal person.
What if both calcium and phosphate is low, and can we give calcium lactate instead of calcium carbonate and 1-alpha CCF?
If both are low.
If both are low, yes.
No, calcium lactate has only very small amount of elemental calcium. Even when you go for a calcium like Calsana 500, we have only 500 elemental calcium. So that means so it's still not touching the required amount of 800 grams of milligrams of calcium per day requirement. Calcium lactate only has less than 100 calcium. So then if you are going to go for calcium lactate, you have to give at least 10 tablets to reach the required amount of calcium for the day. So I think calcium carbonate is much more superior than calcium lactate in terms of calcium replacement, and also phosphate binding.
Phosphate binding. Target serum ferritin for those who are on HD, and the second part is when to stop erythropoietin those who are on HD.
I don't think that we can stop erythropoietin in patient on a HD, so that
HD.
we need a regular erythropoietin. So at least 4,000 after each dialysis if their hemoglobin between 10 to 12. If anything more than 12, you skip few doses and let the hemoglobin to down, and then you restart low dose, maybe low frequency as well. The keep the hemoglobin 10 to 12. So usually my target is 10.5 to 11. And ferritin targets, there's no hard and fast rule and saying that this is the high value. So normally we consider 500 is a higher value when you stop giving like regular IV iron infusions. Normally dialysis patient get 100 milligrams of IV iron monthly basis. So that is to accommodate the blood loss during that particular month. So that is the replacement of iron to the body. So you might stop that IV and supplement if ferritin is more than 500. But remember, so things will come down after a few months. You might restart them when the ferritin levels are come to less than 500. You assume less than 100 is the absolutely low values, and you have to go for a more IV iron for the replacement.
A patient with oliguric AKI with a marginal MAP, can we give IV fluids with IV Lasix infusion and IV noradrenaline infusion combine and observe?
Patient with
Patient with oliguric AKI with marginal MAP, can we give IV fluid, IV Lasix, IV noradrenaline infusion in combination and observe this patient?
We can, as long as you clinical impression of
Mhm.
further recovery. If you think that the patient is dehydrated or volume depleted, and then the optimization of blood pressure will might improve the renal functions, you might keep it going, but make sure that you should not overload the patient with fluid. So you have to restrict the fluid if you are decided, or if your patients develop ATN. It's not, that is not volume responsive AKI. You go beyond the volume responsive AKI, you have to optimize the blood pressure, but do not give fluid, and you have to get the dialysis when necessary. So you don't have to rush for dialysis. That is what I said. So you can wait for the things to build up. If somebody is having oliguria for 12 hours, doesn't mean that you should rush for dialysis. You wait, you see the blood gas, you see the potassium, you see the fluid overload features, and then you can routinely go for dialysis, because always routine dialysis carries good prognosis than urgent dialysis. Sometimes you start middle of the night dialysis, and patient might die because the staff is exhausted, and dialysis they have already done 2 3 shift already, and then going for a third fourth next shift. And also dialysis units, the reverse osmosis is going to get problem, because now there is the water flow change 2 to 6, so that we have to stop the dialysis. So always consider routine dialysis in most of your patient, because you can wait for the next day if there's no compelling indication for dialysis. But remember, fluid restriction is compulsory. If you give more fluid, if you are very enthusiastic to receive urine with fluid, you are going to get the trouble with the pulmonary edema.
Is there a benefit of fusimide bolus or fusimide infusion in AKI?
None of them are beneficial. Uh,
Maybe.
so furosemide is only for the fluid overload, but you can go for a boluses if you have, or your patient is fluid overload. Infusions are not very much needed, because then you have to consider dialysis.
Role of SGLT2 to SGLT2 inhibitors in CKD.
Yes. So role of so CKD, I think now if somebody is having GFR more than 20, proteinuria, diabetes, you must give SGLT2 receptor inhibitors. If a patient having no proteinuria and GFR more than 20, a young person, you must consider SGLT2 receptor inhibitors. So those are the indications. Basically, most of our patients, CKD patients, should have SGLT2 receptor inhibitors,
Yes.
because there's no way that we can limit because even in elderly people, what they say is they are the people who get most benefit from the empagliflozin and dapagliflozin. So then I think in our setup, so what we want, no dialysis and death. So no more complication, no hospital admission. So all can be reduced by introducing this EMPA or DAPA. So I think if GFR is more than 20, so better start them on the SGLT2 receptor inhibitors.
Can we stop erythropoietin abruptly? Example, a patient got 8,000 units weekly on erythropoietin.
You I mean, you can skip doses for the next time, because now it is all depend on the hemoglobin. If your target of hemoglobin is achieved, you can stop, but you have to wait the levels to down and restart, because what happen is sometimes you stop it, hemoglobin 14, you stop it, and then after 2 months the patient come in the hemoglobin again 7, because your issue was you had to skip 1 or 2 doses and repeat the hemoglobin. The hemoglobin values come down, so then you have to restart with low dose. So if 8,000 gives higher values of hemoglobin, you go with the 4,000. So but you have to skip 1 or 2 doses until the hemoglobin come to a less than 12, because if you keep the hemoglobin more than 12, it causes more vascular complications.
If the patient's hemoglobin is not improving with EPO and oral iron, we consider iron sucrose 500 ml as you previously said. How much of an increase of hemoglobin do we expect in 1 month?
Yeah, normally 0.5 to 1 grams of
One per
hemoglobin.
And so patients diagnosed with taltrate and having CKD, is there a particular hemoglobin level we should maintain?
I don't think that we can maintain higher values. So normally more than 7 grams of hemoglobin is good enough, unless they have symptoms of anemia in advanced CKD. It's very difficult to maintain the hemoglobin, normal hemoglobin with the erythropoietin. You have to use very high dose of erythropoietin. So you might not have that facility. And if they might go for a blood transfusion if there's no contraindication for blood transfusion. Otherwise, more than 7 is good enough.
What is the management of ESRF patients with pleural effusions?
Sorry?
What is the management of ESRF patients with pleural effusions?
Pleural effusion. So that may be part of fluid overload.
We
You might
don't.
do more frequent dialysis and then try to get the general fluid overload down. But sometimes you might not be successful. Sometimes we have to go for a fluoridesis, but that had to be selected cases. So mostly more fluid removal with dialysis will solve the pleural effusions as well, but that will be very slow. You don't get very quick resolving pleural effusions, but it will be very slow. But still, if it's not responding, a significant amount of fluid, you might get the chest surgeon's opinion about the fluoridesis.
Dialysis disequilibrium syndrome, can it occur in late stages of dialysis?
Normally, usually not. It is a feature of early dialysis.
Dialysis.
But sometimes, if the patient is default and coming for dialysis, can end up with the dialysis disequilibrium.
Disequilibrium syndrome. Yeah. Please outline the management of uremic nephropathy. Does dialysis help to alleviate symptoms?
Yes, it does, but you have to go with very slow, because if you do over, so patient end up with the brain, the cerebral edema and death. So you have to go with a very slow dialysis. So we go for a firstly 2 hour, 2.5 hours, then 3 hours, so very slowly, and we'll get the time up. So maybe daily dialysis or maybe EOD dialysis, and the once the patient uremia settle, only we move to a twice a week dialysis. You have to be very conservative about the dialysis approach for these patients, because if you do more dialysis, they are definitely going to die.
In a patient with CLCD and CKD, what are the special considerations?
CLCD and CKD. So main issue is, so they are having low blood pressure, and then there's a splanchnic vasodilatation. So you have to address these two issues. So how we are going to address, one thing is a splanchnic vasodilatation. You have to use terlipressin, and then hypoalbuminemia, you have to use albumino, cryoplasma, whatever plasma expander. So when you do that, mostly they pass urine unless they develop a ATN. If they are not producing enough urine, so you can consider dialysis, because now this is mainly a pre-renal. So you had to get these two things upgraded before you consider dialysis, because dialysis carries poor prognosis for these patients. So most patients responding to terlipressin, noradrenaline, and albumin, and maybe 1 or 2 doses of furosemide. So if the patient is not responding with that approach only, you can consider dialysis.
Dialysis. How can we treat high blood pressure?
Sorry, I can't.
How can we treat post-HD high blood pressure?
So you have to use multiple drugs actually. You can't go for a single drug. So what we do is, preferred drug is losartan inhaler pill, and then beta blocker, and then calcium channel blocker, and then alpha channel blocker. So those are the part and parcel of blood pressure management. If the patient is not getting adequate amount of blood pressure control, we can add some methyl dopanol, and sometimes we might have to go for a weight reduction during the dialysis. So that it is like individual decision, but you have to use losartan inhaler pill in all patient on dialysis, and beta blocker in all patient on dialysis if there's no contraindication, and then you add either nifedipine or amlodipine and the prazosin plus or minus furosemide if patient is passing urine. You have to use high dose of furosemide, like 120, 160, 200, because that only produces urine. If patient is anuric, please stop the furosemide.
Thank you very much, Dr. Nalaka, for that outstanding lecture. I think we have got so many questions, and Q&A session went on for nearly 45 minutes. And that shows how important this topic is to the audience. And thank you very much on behalf of the college and the council for accepting our invitation. And thank you very much, the audience, for joining us. We have had nearly about 225 participants online, and we'll join you with the next chapter in August. And thank you very much again, Dr. Nalaghe.
You're welcome. Thank you for invitation.
Thank you. Thank you.